All right, here we go in 3, 2, 1. What's up, y'all? Welcome to the Sports Medicine Broadcast, a podcast to promote and improve your practice as an athletic trainer. So I had a conversation with some of my bosses about where our value is. So my question was, what is important to you? Because as an athletic trainer, we see people posting, oh, well, I've collected this much data, I've done this much money worth of ankle rehab, or this much dollar value worth of ice bags, or worth of manual manipulations, or whatever it is. And so does that matter at all to the administration? Well, there's only one real way to find out. And my administration didn't have a clear cut, oh, hey, these are the dollar values we're looking for. This is exactly what we're looking for. But some of the questions that they had, we're going to go through. And since I'm not very good at I'm not very good at analyzing the data, I asked Scott to be on. And since Daria has a lot of experience with epidemiology, so one of the questions was, what are we doing to prevent further injuries? Well, that's epidemiology. You have to know what's causing it to prevent it. And so we're going to kind of work together to create this situation. And Daria and I have talked before, and epidemiology isn't a strong point either, because it's kind of like, all right, well, whatever, they're just getting hurt. But there's a reason. And so in these conversations, Daria's going to try and dumb it down for me. But, it's something she's excited about and passionate about, so she's gonna talk, and then I'll ask the dumb questions. So without much further ado, Scott and Daria, welcome. And then just give a quick shout out and maybe a little bit of like a 1 minute background of your experience in AT, physical therapy, sports medicine. Daria, why don't you start us?
Thank you for having me. So quick with my background, my undergrad is in AT from James Madison, and then I went to PT school at Seton Hall. And then after that, I was at Penn State for 4 years working on a giant epidemiology project that we will get into, which is where I found a big passion for it and looking at injury prevention. And now I'm currently working as a physical therapist. I'm in an outpatient clinic with Proactivity, and I'm also on site in an industrial setting.
Fantastic. Scott?
Jeremy, thanks again for having me. So I'm also in the industrial setting as well. I did my undergrad and graduate at Kent State University. Been in the industrial setting for about 5 years. Prior to that, I was in the secondary school setting in Dayton, Ohio, and still currently in Dayton, Ohio. I also own and operate my own private business, AT Efficiency, where I collect data and analyze that data from various sports medicine companies across the country. Also chair of OATA's COPA committee and chair of NATA's COPA Analytics and Outcomes Committee.
All right. So this is sportsmedicinebroadcast.com/data collection. sportsmedicinebroadcast.com/data collection, where I'll have the questions that my admin asked listed, some of the tips from Scott and Daria already. Before we even had the discussion, they've got some tips in looking at data collection, epidemiology, and then we'll go through the conversation from there. So I want to start off kind of looking at my numbers. So I gave Scott my injury reports and my daily treatments, my logins for 2019, 2020, right? That's what you did it all from last year, right, Scott?
Mm-hmm.
Yeah. And so
I just did 2019, 2020.
Yeah. And so that's obviously COVID. So that's basically August to March 10th. March 10th would have been probably the very last day, because that's when we started spring break, and we never came back from spring break like most other people. And so we're looking at the data during that window. So Scott, why don't you kind of open it up and kind of show us what you found? He's going to share his screen if you're watching live. If not, then I would recommend going back and watching live there on Facebook or YouTube. So go ahead, Scott.
Okay, great. So you shared with me some de-identified data, and basically, this is from your EMR, and a lot of EMRs out there, you can convert this into a spreadsheet where you can break this down a little bit further. Some EMRs out there even break down some specifics. I wanted to take a look at this and just break it down manually, because that's what I like to do. Because you get a lot of information, and as athletic trainers, we are exposed to a lot of this data on a daily basis, and a ton of it, and it goes into our EMR. So we can really break this down and present to our stakeholders, our successes. We can provide quality improvements to to what we're doing every day. So it's extremely important that we really buckle down and take a deeper look at our data and what we're doing. And I'll provide a few examples of what I'm talking about. So first off, I want to take a look at the questions that were asked here, and we'll go over some of these. So what I have here is I have some tangible and intangible. Intangible are going to be the value saved, the dollar amount, breaking that down. Again, that's always up for debate, and really, in order to prove a point, you're going to need some good research. But first of all, if you really want to look at that value and you want to break that down, my first recommendation is you talk to your stakeholders about what you need to be collecting, what's going to be important for them, right? Because at the end of the day, they're the ones paying the bills, they're the ones that are doing the performance, et cetera, et cetera. So talk to them and see what they want. So it's the athletic director, it's the hospital admin, it's your supervisor, it's the AT manager, it's the PT manager, uh, CEO, safety, if it's in the industrial setting. But talk to them and ask them what they are looking for. So you have the questions here, and here are some of our tangibles. So you have your treatments per week, uh, any kind of prevention practices that protect athletes, common question. So numbers of reported, whether the severity of injuries, and then I have some other ones that I couldn't really answer just because of based on the data. So what I generally like to do is, we need to find ways to improve the quality of what we're doing, and a lot of times that data is going to help us. So let's go to the data breakdown sheet. And what I did is I just pretty simple in Excel. You can do you can format the table pretty easy, and then at the end of it, you just type in up here total rows. And when you type in total rows and you come down here, just real quickly, you can get specifics on like numbers or anything like that. So it's pretty simple in Excel to do. So it's basically counting the numbers and doing the math to see how many are compared to the injuries, etc. So so you had recorded 238 injuries that were recordable that obviously needed some sort of attention, that needed documentation. And this is aside from our daily treatment logs, because obviously with our daily treatment logs, we're going to get thousands upon thousands of entries, uh, just for band-aids, etc. So I broke it down into gender. Again, these are tangibles. These are something that we could look at. So, you had more males, but looking at the grades, the ages, and then the sport. But one thing that really stuck out to me starting off with is looking at the grades. And we had, again, our underclassmen had more injuries. And that's pretty much common because we're getting more underclassmen coming out for specific sports, etc. Uh, but one thing that I was looking at in regards to this is, applying this to your prevention and developing prevention programs based off of um, your underclassmen. And I'll get into that a little bit later. Looking at sport, again, this is stuff that we've been collecting, how many kids are coming in and what specific sports they're associated with. Obviously, football had the most injuries, and that's common ground, with a lot of research out there. You had nature of injury, and the more of acute injuries were the number one, so 75% of those. Um, so when I looked at injury severity, you had mild injuries 79%, moderate injuries are 8%, and then severe injuries are 13%. And I know this is a lot to handle with this topic, especially after the election with all these numbers going back and forth. So I get it. We've been seeing percentages and numbers all over the place. But let's just talk about this a little bit. So Jeremy, just basically what I've discussed right now, do you have any specific questions or something that I missed at this point?
You where you said you broke it down by grade, by age, by sport. basically you took the total and broke down the total by grade, the total by age, the total by sport. Like you didn't break it down by grade and then by age and then by sport, correct?
Correct.
Okay. All right. So Daria, looking at what we've seen so far, what are you thinking?
A couple of thoughts on things. So one thing, like seeing and I should add first, sorry, I'm coming at this more from like a research background. So the goals are like the approach would be a little bit different because I've done things like this too. And so say when you see a difference with a grade or an age or a sport, one of the first things I want to look at, well, what's the exposure? Say, I'm going to make this up. Say one sport had more injuries than the other sports, but they practiced more. Like if you can measure that in time. You could look at practice days, the number of sessions. You could go down to minutes if you have a lot of time and resources. So when you start to look at, I just always say it's making fractions. And you would put, say, like the number of injuries over the exposure, like player days, you're multiplying the number of players by the number of days or sessions, whatever, because that could start to look at some of those. Why are you seeing a difference? It could be a true, like, this is something that happens in the sport, or it could be, oh, maybe they were playing more, or maybe they had more players who were on the team. And then another thing, just to kind of get everybody thinking about as we go through this, is how are you in this case, defining an injury? How are you defining the severity of an injury? Because when you look in the literature, there are different ways to do it. There's not always a right or wrong. It is what's working for you. It could be clinically, this is just in my setting, how we define it. There could be, say, in an industrial setting, OSHA has an injury definition, or in research, you could have your own definition, follow the other literature. So this way we're all on the same page and you know what you're talking about. And then this way, if you ever want to compare data with anybody else, you know you're on the same page comparing very similar things.
Yeah, so that is actually one of the questions that I had in that I saw right there. Is you said there was more male than female injuries. Did you have the total number, Scott, of male and female participants? Because in general, there's going to be more male participants, so it makes sense that there's a higher number of male injuries. So did I give you that information?
Yeah, I looked at it. So there were participating overall. There were 131 males. No, not for the sport. Yeah,
not participating. So that was of the injuries entered.
Yeah, injuries. No, I did not look at that.
Okay. Yeah, so that's something that I would have to go back and look at, like all the rosters in rank 1 and see the total number of male versus female to get the total number of exposures, or like total whatever. Okay.
And that was actually one of my quality improvement type of recommendations, and so one of them was the injury surveillance and the epidemiological surveillance and information that we're getting. So how many athletes, and this is, so when we get into this is a little bit more of a number crunching, but I'm sure you have a bunch of student aides that would be more than happy to collect data on a daily basis that's going to help them in the long run and actually help you. So just a thought out there. But what you're doing is, when you're doing like a injury exposure, you have someone that's at football and you're seeing how many are participating, who's out with an injury, or who's not even there just because of an illness or an appointment or something like that. So every single day, so your numbers are going to vary. So you probably won't have 100% participation, that everyone's healthy and participating. So that's what I recommend. And that's what I've been recommending to a lot of my clients too, is to really look at that injury exposure, because you're going to get more specifics on that. You're going to look at, the lost time injuries, or how long it takes for someone to come back, because you're specifically tracking that athlete. You're also going to be looking at, time loss, non-time loss injuries metrics, which is something that we don't really take too much close of a look at. But then also overall the patient exposures, and you get more of a narrowed down number of what's actually happening. So if you had an injury like 1 in 100, one athlete out of every 100 is injured, and our epidemiologists can go a little bit more in depth with that, just because that's not my strong point. But it's important with the data, and we get a lot of information out of that. So
I'll add to that too. You raised a good point. From the research that I did, so just really quick, I looked at the injuries and illnesses at Penn State sport camps, which have about 9,000 kids every summer in 28 sports. We looked at the exposure with camper days. So I would multiply the number of campers for a day by the number of days that we had. And we just assumed, for the sake of, because this is a giant project, all campers are present at all sessions, all days. You can be picky and actually count. Like, say it's a sport that's going to have multiple practices a day. Well, maybe you have 100% in the morning, but then the afternoon practice, there's less, and maybe everybody's back in the evening. And you can kind of pick how you want to do that. And as long as you and everybody who's looking at it is aware of either you're getting an exact count or you're going to estimate, just because it would be impossible, like, say, my setting, to count for 9,000 kids every day.
Yeah, and that makes it a little bit easier too. That's obviously another route you can go as well. So, that's something to look at in the future. So that's one of my recommendations. But you also had a question regarding like number of I go by interactions because I work in the industrial field, so it's the interactions. So even if someone comes in for a Band-Aid or something like that, you're documenting everything. It's extremely important because we need to know how many interactions we're having. So when we're looking at our monthly interactions, breaking those down, averaging per month 305 almost 306 interactions per month. That's a lot of people coming in. And again, I know a lot of those are multiples. Minusing COVID, if we include these metrics, you're looking at an additional 900. Well, I don't know if you count June as much, but you're looking at an additional, 700 to 900 interactions total. So, it's, you're getting your fair share of individuals coming in. And, I think looking at high schools across the country, that's common. And it's really where our value comes in. And when we look at, when we talk about value, and there's different definitions and value is so subjective. And you could talk to, I've said this before, you could talk to 10 different economists across the country about value, and they're going to say 10 different answers about it. And it's even more specific with different settings. When we look at athletic training, I think the big part of our value comes from the interactions of people that we see. Because for one thing is, that really defines what we're doing within our job scope. We're seeing these people, we're providing coverage, we're providing services, and they're actually utilizing our services. So, the number of interactions is going to be an important take on that. And that's a big part of the value that we see. Another part of that value is going to be the prevention part of it. So you had that question that's talking about prevention. And, I'm looking at it, I felt that it was too specific with what the numbers that you have. But what I would recommend is in your spreadsheet, and you're going through a case by case, and even in your daily interaction log, that if you can put indicators or markers that say prevention, whether it's like a taping ankle or a manual stretching session, that would be important to understand what types of interactions these are, versus just making it more specific in that sense. Does that make sense to you, Jeremy?
Yeah, for sure. We go with what's there inside of at Pasadena High School. We use rank 1, and we go with what's inside of there, and then sometimes in the comments box we'll type preventative rather than clicking the little checkbox. And so obviously it's a fault of the data collectors, which is me and my coworker, but it's definitely a good idea, and it's just a matter of we look at it and then we realize we can collect more or we can do more. Like Daria was saying, you fraction down or something like that. If you start somewhere, so start it, if you're at 0, then at least collect the name and the injury, or the name and the body part, and then maybe next year you start collecting more, something like that. But yeah, it's definitely small tips that can help us make a difference.
Mm-hmm. I'll add to, just to kind of get people just to plant some seeds. So say you have your, a little bit of data your first year, getting going, which is great. And then, so say I'm looking at the number of interactions, which I love that you have that. When I did my research, I call them contacts. I just made up a thing because I hadn't come across it in the literature yet. And so I would look at it as a researcher and as a clinician. What does that number mean? Is that good? Is it bad? I have no idea. So you can say maybe if you have a couple years, you start tracking things, say for interactions, is it going up or down? And you could look at that. Is that good or bad? You could look on the good end. That's great. More kids are coming in. We're getting to know them. They're going to help. Or you could look at it. Is this going up as bad? Because why aren't we preventing things? If we're doing preventative strategies, then ideally numbers should be going down depending on what you're looking at. So that's something to consider. And then even when you're clicking prevention and looking at prevention strategies, whatever they are, you in theory then would want to see certain numbers going down over time. You can either look at your own data that you have or look to the literature. There's tons of stuff that is available on high school, which I sent to you. Tons and tons of stuff you can look at to compare your information to what is being seen nationally. And if you're seeing, well, we started doing this, say a stretching program, and then all of a sudden then the injuries start going down over time. Well, that's great. Maybe that prevention strategy is working. Versus if you start to see the number of injuries are still going up, even though you're implementing a strategy, well, maybe that means it's not working and you should reassess it. So just to kind of take it a step farther, and as you're starting a system, to kind of think, where can you go with it?
Yeah, absolutely. And that kind of segues into my one of my last points here, doing like a comparative analysis with this. So Jeremy, you have this information, and we'll just basically start with this. And one thing that I was looking at, again, as the underclassmen, so the ninth graders were recording more injuries versus some of the other grades. And, we talked a little bit, and one thing that I discussed with you is perhaps an injury prevention program, onboarding injury prevention program focused on underclassmen coming up. So like those eighth graders that are in training prior to the season, you have a specific program for them that's going to educate them more on their bodies to help them reduce any type of musculoskeletal injuries, because that's what the most of them that they were encountering, musculoskeletal injuries. We have them here. So I think that's going to be important. And in the industrial setting, that's really what we do, is we look at, where are the weaknesses, and we focus on those. So, we start small, because if you start huge, you're just going to overwhelm yourself. So start with a small group. That's going to be our underclassmen. They're going to be more likely to go through a specific program with you. Educate those coaches too on what they should be doing, especially freshman coaches, and take them through that and see if this works. Implement that and see next year with those numbers, did those numbers come down with injuries in regards to underclassmen. And then another point too is with your football concussions, 7 of them were freshmen out of 12 concussions during football. And really, to me, that's more of another education issue with hitting. And again, this is based off of my thoughts and my recommendations, and looking into maybe head impact monitoring to see if, whether or not they're making contact or hitting properly or something like that, or even not even investing in that, but really talking to those freshman coaches or those coaches to just hammer home the importance of not leading with your head or blocking or something like that. So again, from that data, that's something that I obtained. And again, some recommendations with that, and to compare that to next year to see if those numbers go down, if we really do that education piece. And that's going to be your most important part, and it's going to be the most cost effective, because essentially with the data that you have, you don't have to really invest into anything. And I had the head impact monitoring. I know this can be expensive, but really hammering with those freshman coaches the importance of hitting in proper form with those young kids.
All right, Daria, what you got?
I have many thoughts right now on things. I kind of want to jump back for a second, because we had sort of brought up time loss injuries. And that's an option, is something that you can look at too when you are determining how you want to classify an injury. And it could be like an ankle sprain, grade 1, grade 2, grade 3, something that's standardized, or it could be whatever fits your setting. What you'll see in the literature is, was there a time loss from the injury? Meaning, do they actually have to be held out of participation due to whatever injury happened? And that time loss could be an inning, it could be a quarter, it could be a game, it could be a session, a week, whatever you want to make that is like your mark. And that's something you can look at too when you're looking at all this other information, is of those injuries that are happening, which ones are actually severe enough to be holding them out of participation, and maybe looking, is there a commonality with it? Let's say, like, look at the concussions, like if everyone's hitting with their head down and that's what's happening, that's a pretty straightforward thing to find. But if you're seeing, well, for everybody who is having to be held out of at least one practice or game, whatever you pick, maybe there's this common trend. Maybe they didn't warm up first. Maybe the field conditions were really bad. Maybe they weren't in the proper cleats. Who knows? Something like that. But looking for those other little things too, which is where there's a benefit to looking at time loss. And then going back to, like, how are you defining an injury? In some studies, an injury literally is defined by time loss. If time is not lost from participation, there is no injury. And that is completely, whatever the choice of whoever's looking at it. But I think a really important thing to consider.
Yeah, absolutely. And you can go extremely specific. And with COPA, A&O committee, we did release a survey last year talking about value and data collection, and a lot of the stuff that kept coming up was the time component. And and I get it. And in a high school, when you have 60 kids coming in at one time, it's a little bit easier. In the industrial setting, we don't have as many patient flow, and we can track more specific information. My recommendation for you is, if you're in a secondary school, college, university, and you want to get more involved with data collection, just really start slow, and don't overwhelm yourself, because once you start overwhelming yourself, that's when you don't want to continue to do this, and it's extremely important for you. But that's a great point. Field conditions, you're looking at different variables, and a lot of the EMRs, you can click that, and it makes it much easier to that. And if you're not seeing that with your EMR, reach out to them, because I'm sure that if your company or organization is paying for it, they'll probably customize it to fit your needs as well. So we'll go into this last bit of information that talks about the cost, and we'll go through that, and I'll just discuss this a little bit more in depth, because it really comes up a lot, and it depends what setting you're in, whether or not that's going to be as any importance to you. And I talk about this a lot. So I went through, and really I did just a basic sweep of some of your information, looking at your injury reports. So generally, on average, and I'm getting my information from this study, and there's a ton of studies out there. There's a few studies out there. Cost of injuries, so from a North Carolina high school athletes, and this was in 2007. So I incorporated an inflation percentage on it. But in an industrial setting, we rely heavily on this. It's helped save my job several times, just by discussing the cost perspective to some CEOs, and what they're paying. But from this study, the mean medical cost, and this is coming out from outpatient data collected from athletes that have gone to the hospital that have received some care, was about $709 per athlete on average. In inflation's perspective, it's $890 right now. So that's our direct cost I look at, and then we also have to look at our indirect costs. And according to this study, it was $2,223, which inflation-wise is, I believe I have it on here, $2,700. So what I did with this is I just took that number, 800 for every injury, and then you had your indirect cost for every injury, and let me see here. Oh, and the cost that I got is a projected cost savings. So direct cost 168,000, indirect costs 527,000, total of almost $700,000. So if you go to your AD, and some of you go to your AD and show this to them, they might not even really care about this. It's you have to ask a few different questions, like, well, where's this money coming from? Are these true dollars? So when I first started doing a lot of this, I was really excited about this. But the more research that I read into it, the more I was looking at it from saying that this is good, but it doesn't really represent everything. So you have to take a look. And when I look at the specifics of dollars, you have to take a look and ask yourself, well, who are you saving money from? Okay, so there's different schools of thought. So, Jeremy, you're directly employed with the high school. So, you could say that you're saving the school district, you're saving parents money, and if you show them that, hey, they worked out with me here, and I saved them X, Y, and Z money, they might be happy. But what I look at it too is reducing unnecessary trips to the emergency room, and that's where a lot of the costs do come from. And if you look at it now, emergency rooms are very dangerous places to go for a mild ankle sprain, right? So that's a part of it right there.
I'm going to jump in really quick.
Yeah,
I have
sure.
something real quick to add. This is interesting. So when I was looking at all these Penn State sport camp injuries, one of the things that they had started recording, I had to make it really fast. I had 4 years of logbooks that were very not helpful with very minimal information, and then 2 years of I implemented a paper-based system to get more information. But through that whole time, even before I started, they would track anytime they had to take a kid either to the emergency department, to the health center, whatever, to out to see a physician. And I had 6 years of data from that. And there was a whole amazing system in place to make sure we were triaging kids appropriately. They're only going when they have to, that, we can handle stuff in-house as we are trained to do. And this is not like an apples to apples comparison, but if I remember correctly, of those 6 years of data, only 9.9% of all injuries and illnesses, there's a lot, had to go be seen by a physician at the hospital or a doctor's office, versus looking at, there's a neat study called the Healthy Camp Study nationwide, looking at just general overnight camps, and about 60% of all of their injuries and illnesses got sent out. And so it's one thing that kind of speaks to, obviously, our role and the importance of having athletic trainers present and being there immediately to help assess and triage things. And that, from like cost savings, that the cost would be to the parents and or to the camp, depending on like the nature of what had happened. And then also, as you were saying, like, yeah, cutting down just on unnecessary visits in general. If stuff doesn't have to go to the emergency department, if it does, you don't have to unnecessarily be exposed to radiation, X-ray, being prescribed pain medication, things like that. That's a fantastic thing to do. And that's an easy thing you could actually add into recording. How many of all of the kids you've seen, how many have to go to the physician? And you could even, I added tracking, what was the official diagnosis? We suspected a fracture. Did they actually have a fracture? And just kind of looking to like how, was everything kind of lining up? Or were you sending, I don't think you do this, but tons of kids to the hospital, and most of them, would be fine. But that's a really, really great thing to look at, especially now as you brought up trying to minimize being in a hospital.
Yeah, especially with COVID. So it's so what I would recommend is I would definitely look at, Jeremy, the ER and really breaking those down, the specifics with that. So if you look at what you're doing, and say for instance, we'll take the ankle sprain for example. You're not too sure if it is a fracture or just a really bad sprain, but again, it's non-life threatening, and you say, hey, let's just work with me for a few days and see if it improves. And based off of your knowledge and your expertise, and you see that we're seeing some functional improvements here, swelling's going down with just basic treatment and rehabilitation, then you could basically put that down in your notes as that individual did not need to go to the ER, and that's saving a ton of money, but also that indirect cost. We all know ER visits are not cheap, whether it's coming through our insurance or whether we're paying out of pocket. Again, when we look at that number, those numbers, there's so many variables out there. There's the insurance, there's what region you're in. New York City is going to be different from Dayton, Ohio, on what you have to pay. Versus Houston, Texas. So there's so many variables. And, I've looked at the CMS, and then in California, there's like over 15 different areas where there's, when you're looking at CMS, and it just varies by a few dollars to a few cents. And it's really not worth looking at that. But if you're really looking at the emergency room costs, I mean, we're helping out a lot in that regard. But I did want to real fast go over the indirect cost of, and in the industrial setting, we talk about that a lot. But according to several studies, one of them being the Stanford study, and it looks to me like the same study, but for every direct cost, it's about 5 times the indirect cost. So, when you look at high school kids in general, looking at what you're doing, generally, there's no like, value cost on them not participating in their sport because they're not getting paid for it. But say for instance they do have a part-time job that they have a knee injury, they can't really do much, or their parents are taking them to the doctor's office and the parents need to take PTO, or they're not working, cost of mileage. That's where that indirect cost goes into that. So but as far as looking at your data, again, like I said, I'm really happy with what I saw, because generally when we talk about documentation, we're really trying to get athletic trainers to document everything across the board, more specific now more than ever. And as part of being involved with COPA and advancing the profession, that's really where everything lies. It's the data collection, and to get that data, it's the documentation.
Yes, I'll add into that just from my own work that in Excel, the columns literally went from A to AY. That is how many variables I had. There's so much information to look at. Don't do that. I don't recommend that. Start small. But there's always so much that you can do. I'm going to go back for a second, going back to emergency departments. So one thing that we found, and this is a really neat combination working with a graduate research program, Penn State Sport Camps, in athletics, and everybody kind of coming together from different points, was they had changed their system. Previously, most kids were either going to the emergency department or the health center, which weren't really necessarily the most appropriate for non-emergent orthopedic injuries. So you could take the information you have and then look at, is there a local, one of the orthopedic urgent care kind of things open later that would be more appropriate than sending a child to emergency department when it's not a true, life-threatening emergency, and start to reach out to the physicians too. Where I had presented the trends in our physician referrals at the American Academy of Pediatrics conference. And they were super interested in that, because that's great on the physician's end. They're seeing more kids, they're happy, but it's also getting kids the appropriate care that they need, where we all know not everything needs to go to the emergency department. So that's another thing you can look at. What injuries did you have? Why were they being sent out? And was that the best choice? Sometimes that's the only choice you have. I know geographically, sometimes it's the hospital's the closest thing, but that's a great talking point then, to go to your local physicians and say, hey, here's what we're looking at. We have these kids being sent here, but I think you might be a little bit more appropriate. Can we work something out? Can we have a program?
Yeah, absolutely. And I think it's also important to focus on the outreach athletic trainers too, that when you look at it, that they are getting, that's how a lot of programs justify their program with revenue to the hospital if they're referring out to the hospital. There's mixed opinions about that, because again, with athletic trainers, if we don't feel like they need to go see our orthopedist, there's no need to send them out for that, because we can take care of it. But I think athletic trainers act as a great gatekeeper, and to help be that liaison within that huge hospital network and organization. And I think that's where a lot of that value comes, because you're trying to get an appointment with an orthopedist can possibly take 6 weeks, right? But having a team physician and an athletic trainer directly working with them through that organization and that hospital, they can get that athlete in possibly within the week, or that physician, if they come there. And I don't know your situation, Jeremy, but that physician can see them right then and there. So I think that's a tremendous value for a lot of these organizations. And I get that they need to track that information, and they obviously should, to look at that downstream revenue. And it's going to be important for that. And you could get more specifics too, but then you have that question is, well, are those numbers and totals, are they directly related to the athletic trainer? And I would say yes and no at the same time, because you have that direct referral, and a referral always counts as something. but especially if you're performing that procedure like that ACL surgery, well, obviously that's going to be that on that physician. But you get into some gray areas, and you get into some good discussions that I think we should really talk about more, because it's extremely important, because it shows our value. But then also there's going to be debate around it, and we're going to need to provide the research, and we're going to need to discuss our position when it comes down to some of these downstream revenue costs, in discussions as well.
So Daria, I know you haven't looked at all of the data and crunched all the numbers like you've done before during your research studies, but what are some of your thoughts as far as epidemiology, preventative practices, preventative things for us here at Pasadena High School?
Like specific strategies you can use?
Yeah, so kind of looking at the numbers or the things that Scott showed, or even if you looked at all of the data in there, what are some of your thoughts?
Well, one of the things I remember what stood out, I saw there was like a bunch of hamstring strains, and I was kind of like, is that the same kid a bunch of times? One thing. So just as like a side thing, and that teasing that out, so then you could pick out, all right, is that one kid coming back because it's a follow-up versus like, are there like, is it just a lot of kids on one team who are having hamstring strains? Because you're looking for those trends too. I'm going to give an example just from the Healthy Camp study, because it's just a really great study. They had found that just in their first year of collecting data, there were injuries happening because people were not handling knives correctly in the kitchen, and because kids were running in sandals and flip-flops. So not even doing a formal study yet, just, hey, little things, let's educate people on how to use a knife in the kitchen, and let's say sneakers only, cut down on those injuries dramatically. So sometimes it doesn't take a big, fancy, sophisticated statistical analysis. You can just see, are there little trends in there? And that's where it comes down to looking at, and some of this depends on resources, but how detailed or not are you with recording the mechanism of injury, like anything associated with the injury, and then better trying to tease out how can we prevent it. Because you make general statements. Obviously, we're seeing a lot of muscle strains, maybe we need to stretch and strengthen better. Or it could come down to like a specific thing happening in that practice or game or whatever that's leading to those injuries. So when it's possible, trying to find like a little more, when it's feasible, information to then have more specific strategies. It's one of the things, like in this industrial setting too, we're looking at like honing in on other specific tasks that are, when something's happening, is it an acute thing? Is it kind of stuff that's building over time? Is this something that maybe not be classified as an injury, but there is an ache, a pain, an impairment, or a dysfunction too, which gets a little more into the clinical side. But looking at that also, maybe there's not a structural injury, but if things kind of keep where they're at, it might become one. So having a way to, if it's possible, to record things like that to account for it. And then when you're looking at the preventative strategies, again, going back to those numbers and seeing, are they decreasing over time like you would expect? Because I think sometimes we think things are preventative, but it's just what we've always done. So let's get some numbers on it. And things can change. There could be old studies that show something, and now in your setting, that doesn't actually apply. Like my sport camp setting is so different than what you would see in a high school setting, seeing kids through a whole season or a whole year. I would see them for a week. So looking specifically at your own unique situation, and are the strategies we're implementing actually helping, shown by the numbers. I actually kind of want to jump in with another thing really quick too. I just want to go back to value before I forget. So with sport camps, this is a neat thing. So when I started this, it was just on a research standpoint, we're just describing what happens. That's it. We weren't trying to find something specific. You're just describing what's going on. No interventions, nothing. And completely not on purpose, it ended up getting us paid more and increasing staffing. Because while I'm doing it for my own research purposes, we were able to take it to the administrators, able to take it to risk management even. They loved having all this information. And it showed, hey, at these certain camps, look, here's our workload, which I didn't mean to show, but it actually showed our workload. So maybe these camps need a couple more ATs or students because there's so much volume. Maybe during these weeks, we need more people taking kids to the doctor. And look how much we're working. And actually got us paid a little bit more. So when you can start and say, I don't even want to start doing this because it is so much work and I'm very busy, you can be surprised on what's going to come out of it. It could just be nerdy and you have a bunch of numbers that you like to look at, but there could be things that you can take to the athletic directors, you could take to the coaches or whoever else are stakeholders, and they might find something that you weren't even thinking about.
Yeah, absolutely, Jeremy. And we talked about this last time I was on in 2019 about, I think it was at the time we talked, I was tracking this for about a year or two, and I increased my salary by 28%. Right now we're probably, I think when I looked, is about 40% since I've been doing this, and so we're looking at about a 10% increase per year, just because of tracking value. Uh, and I've talked about it before, though. Having this metrics has helped, you know, sign our contracts for an additional year or two, just because we are tracking this information, and it goes into a little bit with some of the OSHA net metrics too. But it's been really valuable and important. And talking to some ATs across the country with what's happening with COVID, we've had administrators ask for their numbers and they just don't have it. And could that have helped with reducing furloughs? I don't know, but it's something that could have helped add more push with those metrics to help with those individuals. So it's really helpful to rely on numbers and to continue to track this information. So moving forward, again, with your preventative measures, looking at those specific, I did looking at generally, what I would recommend is, instead of being bombarded with a year's worth of information, break it down by season, break it down by even months too. You could do that, and look for that specifics, because you're going to have more time to look at that. If you saw an increase with your girls soccer team in August of 2020, that they had an uptick in injuries, knee injuries. Well, what's going on? Is it the turf? Look at those field conditions. Is it, is it something else?
So there's a couple of things that have kind of come to mind. Daria talked about getting them to the appropriate medical facility. So here at Pasadena, we're partnered with Houston Methodist, and the hospital works out a deal with the school district to where pretty much the school insurance covers everything for a doctor's visit. If there's surgery, then there's other parts involved and there is a cost, but it's still greatly reduced because the school insurance will pay for pretty much everything that the hospital owns. So like the anesthesiologist or MRI, they might not own, so if they're contracted out, then they have to pay for that. And so it'd be interesting to see the cost associated with that, because we're partnered with it. If it's already reduced in and of itself, I would assume that it is. And then another thing is, here at Pasadena High School, we have, I think, 6 girls on the varsity basketball team, and they're waiting for volleyball to finish because it was pushed back, and now they overlap for 4 weeks. And then there'll be 4 girls that transfer and go straight from one to the next. And so some of the things that are just interesting to see is, how do I categorize, okay, well, this is a volleyball injury, or this was a basketball injury, or that kind of things, or maybe this was deconditioning and because of COVID, or this was she just hadn't been able to make the transition, or this is overuse. And so there's obviously a lot of possibilities, a lot of questions that could come up. But what do you feel like is the basic for somebody who has nothing? What maybe four things that they have to collect? 4 things they have to collect. So Daria, Scott, I could see Daria's considering.
Yeah.
Right,
I'm thinking, I'm going back to when I would look at these old injury log books and pulling my hair out on why is there information. Body part. That seems really obvious, but you can be as specific as you want and then later on generalize. You could be the distal phalanx and later categorize that as a hand. But if you have a little more detail up front, you can always generalize. But if you only put hand, you necessarily can't go back later and find more detail. So body part, very specific, that's important. And even a dominant, non-dominant side. What else? My clinician brain is always curious more on the interventions. I guess when you have rehab listed or something, I'm always wondering what kind of rehab, which is a little beyond kind of what we're talking about right now. But even that more specifics, you could even try this group's going to do this for a hamstring strain. This group's going to go this route for a hamstring strain, and see if there's differences if you have that extra time and those resources, but kind of not just grouping rehab, stretching, or whatever these broad categories. But again, have a little more detail. And later on, if you just want to group it together, that's fine. Some of the things you have are already great, like having age and having grade, having sport obviously is good. You can always categorize sports into comparing the contact, non-contact, and collision sports. So I know sports are year round in every season now. So if you want to look at like, are they in season getting this injury pre-COVID, or are they out of season practicing year round getting this injury? As you brought up, things are overlapping. You might not be able to account for, well, if they're overlapping, is this volleyball or basketball? But at least just note like two things are going on at the same time. And you might see, I wouldn't be surprised if there's a trend with that. Kids are having to go right from one sport to the other. The timeline is completely off now from what they're used to. That could be leading to injury. So just making a note of that. If this is, are they doing two sports at once? Are they maybe not now, but are they also on a club team and playing on their high school team and doing multiple things at the same time? That could be leading to an injury increase.
All right. So, Scott, I've got body part interventions in sport. I think that's kind of what Daria said there for 3. So what's, if there's one more thing, four things that we're going to collect, only 4 because we're brand new to this. What do you think? What would the 4th be?
So would this be daily interactions?
Sure.
So, yeah, it's always tough. So we have gender, body part, and sport. I would just go back to the interaction. I know we've talked about if it's broad, but we could keep it broad. So you have, on here, you have exercises and modalities. Well, I would consider those 2 separate. These are just 2 categories. I would consider these 2 separate interactions. So, say for instance, you have, and you're going to be very specific. So you have someone that comes in for an ankle, and it's one kid, but they are going through their exercises. That's one kid, that's one interaction, exercises, and the next thing is they get taped. That's another interaction. So you're keeping track of that same kid, but they're having 2 different interactions versus just putting it on the same line, because that can get all muddled. So then when you have one of your questions here, when we were looking at rehab, when we're looking at budgetary stuff, how much tape are you going through? You can estimate like the cost of tape versus what brand of tape that you're using, and you're going through an ankle tape and they're using 1 roll of tape. You could break that down to say, this is how much tape I'll need next year for this specific sport. So my last one would be intervention. I would say, are they getting and keep it specific with this one. You have a list of 10. Are they getting rehab? Are they having a modality? Are they having tape? Are they having wound care? And then you can really break that down in the end to see how many specific interventions that they were having throughout the course of the year or season, different individuals.
All right. So Daria said body part. She said interventions, and she said sport. And so you could put boys basketball, girls basketball. So then should be getting gender and sport at the same time, which could be grouped, and then obviously. So if there's one other things, I know you said interventions, and then that's so much you can break down more, but we've got a list of 3. We got body part, interventions, and sport. So are those the 3 biggest things?
The date too,
Date?
Obviously.
Okay.
Yeah.
What do you think, Daria? Is that one of the important factors there?
The date?
Yeah.
Yes. Yeah. That's actually important. I mean, granted, when I was looking at date, it was just tracking over like a week or maybe 2 weeks max. But you can look, like if you are trying to track specific kids or looking at, you can go back then and see, is everything happening at the end of the season when everybody's just exhausted? You can argue is at the beginning of the season because maybe people are just getting like reconditioned again, trying to find those trends. And so without the date, you wouldn't necessarily know that.
So also, I would say maybe a caveat to this is the time spent with that individual. It's going to be a little bit harder, but it's like, so say for instance, you're taping someone's ankle, you could put in how much time you spent with that. You could say 2 minutes, or if they're going through that rehab, you can say 15 minutes, and that can give you an indication of how much time is spent with each individual, with various interventions, and you can track efficiency and plan out your day, etc. If those same individuals are coming in. So I wouldn't really count that as an essential, but it's something to take a look at. And I track the time I've spent with individuals too.
That's a neat thing to look at. Like my clinician brain is saying, if you had a lot of time with kids spent on passive modalities, maybe not the best always. So as a clinician, that would be a really cool thing to look at. Like how many kids are doing active things, doing things that you teach them what to do and they could come in and kind of work on it on their own, versus how many might need you more one-on-one, say it's like a new post-op or something, versus like I'm just coming in to hang out with my heat pack because it feels nice. And then looking at like how if time is difficult because there's so many kids and very few of you, looking at that time allocation and like, all right, well maybe this isn't like the best use of time here, but this is like the really important stuff that actually like needs to happen. What can you change possibly, or what can you delegate if there's more people who can help you?
So just
Yeah,
go ahead.
yeah. No, I'm just saying that there's just so much that you can like. You can have a spreadsheet full of stuff, but just start off with your first ones. Yeah, like you said, obviously the name of the individual, the grade, the date, the intervention, and the body part. It's good to start off with, but then you can expand on that. We can look at more specifics. We can look at your notes. We can look at if you want to add a cost savings multiplier in that. Just look at your CMS conversions for your area. Then if you want to put in an indirect cost factor, that's going a little bit in depth, but adding a time factor may be your next step.
So a lot of caveats.
Yeah, a lot of caveats. A lot of stuff to add.
Yeah, but I'll add a little thing with CMS just because I work with third-party reimbursement as an outpatient PT. So just something to consider, because if somebody doesn't actually work with third-party reimbursement, they might realize, like with CMS, with Medicare, guidelines, things that have to be done, there are limitations on things. So if you're using if you're using those monetary amounts, just be clear, whoever you're presenting it to, that it is as though there is unlimited reimbursement, because in the real world that definitely doesn't happen. There are caps. It depends on the policy if there are visit caps or dollar amount caps, or there's all different things. But when I've seen that being used, it assumes everything is going to reimburse unlimited, which isn't true. So then that like savings is a little overinflated. So it's an option. It's just be aware of like what that is actually showing, because the real world, they will not cover everything.
Right. And again, it's just to use as an illustration, to highlight the value piece of it. And it's not, I wouldn't say it's essential, but it's an additional piece to that puzzle.
So Google Docs, Google Forms, so you can make an easy one in there, and I've used it as an example. And again, there's always the question of the HIPAA compliance. So if you're going to use Google Form, you have no other options, then don't put any identifying information, as in like student ID, student name, anything like that. Don't put that stuff in there if you're going to use a non-Google Apps for Education, because those are marked as FERPA compliant or whatever it is. But so if you're going to use Google Forms, then that'll automatically capture the date and the time once you hit enter, and then you can easily separate that out by just searching how do I separate columns or whatever it is, and then that can give you that data, and then you can ask those 3 questions: the body part, the interventions, and sports. And using a Google form, you can easily select, okay, you can put 10 different interventions, ice bag or rehab or whatever, and then as you collect that data, then maybe the next semester you say, okay, now I'm going to put 20 different interventions, or whatever it is, whatever it is you see that you need or you decide you want to try, grow from there. But they say body part, obviously it's important. Interventions, sport, and date and time, those are good informations as well. One of the things that I wrote down here is we need at Pasadena an incoming freshman or an onboarding program to help prevent injuries. And so that'll be Sophia, my coworker. She's really good at looking at that stuff and creating a plan. Now it's a matter of us communicating that with the coaches, saying, here's what we're seeing, here's what we think is one of the causes. We've consulted some other medical professionals, and they said this is a good idea, a good plan, a good way to do this, and here's what we would like to do. What can we do to build that program? So again, working together, communicating an onboarding program for the freshmen, and then some of the things that we may need to add is making sure that we use the checkboxes or clicks inside of our EMR, which is again rank 1 here at Pasadena, and so that we add the required a doctor's visit button, or we add required surgery, or time missed, and whatever we define that as if we define time missed as 1 day, okay, then every day they missed practice or didn't participate, then we need to be able to click that and say they missed today, they missed today, they missed today. And so those are some of the good takeaways that I've got here. Any other closing points, takeaways, thoughts that we, kind of need to sum up or rehash?
I would just say, add that injury surveillance. That's gonna help you in the long run. To look at the look at the exposure rate.
Exposure rate, okay.
Mm-hmm.
Yeah, and going off of that, even if it's not everyone's favorite thing, be nerdy, read some journal articles. There are so many neat epidemiology studies, whether they are specific to sports in a certain setting. There are some really interesting ones. There's stuff that might not directly pertain to what we do, but are kind of related, and it might give you some ideas, and you can see what exists. Not that you need to be running statistics, but just see what's out there and give you some ideas for how do I want to define things for what I'm trying to do. As I mentioned earlier, comparing it. Well, here's what I have, and let's see nationally what's existed, because there are many national high school studies. The NCAA has tons of studies too, and just to give you an idea of where do your injury rates or whatever stand compared to what we're seeing at a larger scale. And then also, I can safely say this, that reach out to epidemiologists if you have any questions. There are some amazing athletic trainer epidemiologists, and I'm sure they will be more than happy to answer your questions too, because this is what they do for a living. I know we sometimes have a tendency to say, oh, those are the researchers or the academics, but they know this stuff inside out and will be so helpful. This has been going on for many decades. So reach out, ask questions. They will be very happy to help you.
Or start a podcast and get people like Daria and Scott to do the work for you.
There you go. You're a smart one.
All right. So again, this is not a strength for me, but it's something that over the years I've realized the value. And again, start small, like they said, narrow it down to preventative programs, get little victories, demonstrate the importance of staying healthy. Daria says, establish your goals. And again, we're going to be talking more about goals. So on that, I think I just put it out on Instagram. It was yesterday. We've been asking this question for pretty much all of this year, is what percentage of 100 are you today? And so the kids right before that would answer 0 out of 10. 10 is the worst pain you've ever felt in your life. I'm a 3. I'm a 9, whatever it is. And then we'd follow that right up with what percentage of 100, so we could write that down, make sure we put that in there. So they were combining the two, in their head. They're like, oh, well, my ankle is at a 2 out of 10, so I guess I'm 80%, that kind of thing. And so just yesterday, two of my kids were like, what are you always asking that same question for? I'm like, I'm not. I just want to see how you're doing overall. How are you feeling? Because maybe you didn't eat breakfast, maybe you got in a car accident, maybe this, so overall I'm at about a 50 because, my parents just got divorced last night, or, what, I got a broken ankle, but hey, I'm 95. I'm good. I'm great, And so that's one of the cool things that when we talk about goals coming up that we'll discuss, and what I've done, what I've failed with, what I've succeeded with, and we'll go from there. But I think it's also important in collecting data, just because you're seeing, it's easy for me to see, okay, well, hey, yesterday you were at 90%, today you're at 91, tomorrow you're at 92, that kind of thing. So it also helps in collecting that data.
And I think I think we spared your audience because we didn't go into patient-reported outcomes at all, and that's its whole other podcast.
No, we've done a couple of talks like that, and so yeah. So it kind of keeps coming back to that. So those patient-centered care, the patient-reported outcomes, collecting data, because they all work together, which, it's just a matter of practicing one, and you see, oh, well, now I can use this data that I'm collecting to improve the patient outcomes and focus it more on their center. Because I also ask, what is your goal today? Well, I just want to make it not hurt. I just want to know it's not broke. All right. And so all of that is good to record in there, but start small. Do the little things, and you can grow from there. Daria also recommends having clear operational definitions, have objective measures to quantify preventive strategies. And again, that's what we talked about, the exposures, and you're looking at, 2-3 years worth of treatment and seeing, okay, well, the girls basketball only had 1 ACL instead of 4. Next year, we're obviously, there's going to be some, and sometimes it just happens. But if we can over time see a decrease, then we're doing good, but we have to collect that data and we have to mark it as preventative, so we can see there as well. And then she just said, look to epidemiology literature, go beyond the big numbers. Don't get consumed with, like we said a couple of times, I did 10,000 ice bags, each of them worth $10. So there you go. That's $100,000 worth of ice bags. Don't get lost in that. Okay. I mean, if you're trying to wow the booster club into buying ice machine, then okay, you got to do what you got to do. But make sure what you're doing is useful. Like they said, find the questions that are helpful for the stakeholders, and then in your documentation system, whatever you choose, whatever it is that you have, make it useful for you. So capture the desired variables. We already said those 4 at the beginning, or those 4 were the minimum crucial ones. Again, going back to body part, intervention, sport, and then date, and then time if possible. But, again, depending on what you have, most of those, once you click enter, it says the date and time automatically. So capturing those variables, grow with those. So I think we've kind of covered and then recovered everything that we've gone over here. And I feel like this is another conversation, probably like in a year, to see if I've done any of this stuff and where we've changed. So we'll kind of plan on that, maybe in about a year, just looking again at the data and seeing if we've made any improvements. All right. So if someone wants to get a hold of you, Daria, I have your On Tap Physio on Twitter.
Yep.
Is that the
best way to contact me?
All right.
Yes.
So cool. Very active on Twitter. You can get a hold of Daria at On Tap Physio. So there are 2 P's, On Tap Physio. And then definitely she's, like I said, she's always on there. Get a hold of her there. And Scott, best way to get a hold of you?
My email, sm@atefficiency.com. And then on Facebook, I also have a business page, AT Efficiency. Just type that in.
All right. This is sportsmedicinebroadcast.com/collection. So I have a link to Daria. I have a link to Scott, to AT Efficiency. And then any of the research articles that were sent to me, I'll have those linked in there as well. So again, I enjoy seeing these things because you put them together, right? So seeing the numbers that you guys have crunched, or hearing the things that, here's how I can make my program better. So I really appreciate this conversation, like personally here at Pasadena. And so this helps me grow. And if I'm in the secondary setting, then it's got to help at least somebody else grow and provide better patient care. So if someone wants to get a hold of Daria or another epidemiologist, reach out. She'll point you in the right direction. Super helpful. We've interacted quite a few times. And then Scott, he's been on here a few times as well, talking about everything there. So sportsmedicinebroadcast.com/data collection. Again, sportsmedicinebroadcast.com/data collection. And there's a lot of resources and links there in the show notes, and you can get all that information there. So Scott, thank you so much. Daria, always a pleasure. And for the Sports Medicine Broadcast, that is a wrap. Thanks.
Thank you.
Thank you.